Good morning, everybody. The topic is choice of surgery in subaxial spine injury. We do know that subaxial spine means injury, and basically means CT to T1, and 50 to 64% these injuries are associated with traumatic spinal cord injuries. The most common classifications, even till now, that is used is the Allen Ferguson's classification, which divides the fractures into 6 common types, depending upon the position of the head and the direction of the force applied. But I will be discussing about the most common subaxial injuries, the burst fractures, the uni and the bifascial dislocations and the fracture dislocations, and certain aspects regarding the skeletal management, not taking into account the spinal cord injury of the patient. The question always being when to go anterior, when to go posterior, and when to go combined. Let's first start with the burst fracture. This is a 30-year-old male patient with a history of RTA, HSC neurology. As you can see, the radiograph, the patient has got a burst fracture. It's basically a compressive flexion type 3 injury involving anterior teardrop injury involving the C6 vertebral body. And it can be well appreciated here in the CT and MR that there is a shortening of the vertebral body, there is comminution and retropulsion of the vertebral body into the canal. Even though the plain radiographs, you can see here there is a widening of the interspinal spaces, but if you look at the CT and MR, the injury posteriorly is not that significant apart from fracture of the lamina. The question comes as to what type of surgery to do in these type of burst fractures. Basically in the cervical spine, especially in these situations, when you look at it, the compression is anterior and the structural failure is anterior, and therefore an anterior approach would be an ideal in these situations. A few things about the techniques. Basically, you may have to use preoperative traction or intraoperative traction if there is a delay in your operating, for realignment and partial decompression by ligament axis. The classical Southwick-Robinson's approach and decompression is necessary after the PL. You can use a burr to do that, but in case you are using a cage, then it is better to use a nibbler to remove the anterior part, and probably the posterior part can be removed with a burr or with a curette. Then next, the second question is how do you reconstruct after you do a corpectomy? You can use the iliac graft, which is of low cost, but there is a downside morbidity, or you can use a mesh cage, or you can use an expandable cage. And this patient underwent an anterior corpectomy and then followed by iliac crest graft, eventually going on to have a good fusion. Therefore, is there a role to do a posterior surgery in a patient with burst fractures? Ideally not. In a patient who has got a burst fracture, a standalone posterior construct is not an ideal, and a lot of time because the anterior compressed vertebral body tends to collapse and usually it tends to lead to failure, not an ideal like burst fractures. But there is a role for theoretically there is a role for a combined approach. Whenever there is an associated significant posterior ligamentous injury, you may have to think of a combined anteroposterior procedure. And this is what the literature does say. But however, in our experience, the majority of these patients, as in situations like this, again, the anterior teardrop with retropulsion and a widening of the interspinal sclerosis, it can be treated effectively by doing a corpectomy and anterior fusion. Similarly, in this patient, if you see here, there is a significant retropulsion, there is an injury to the posterior ligament, not only of the lamina, there is a segmental fracture of the lamina. The interspinal ligaments are also injured, but these can be treated adequately by an anterior procedure alone. But however, it's important to remember that when you are considering an anterior alone procedure for a patient who has got an injury both to the anterior and posterior column, these patients need to be supported with an external immobilization for a short duration of time, at least for a period of around 4 to 6 weeks, till the posterior ligamentous structures heal. Whereas when you do a combined anteroposterior procedures, that in that situations your external immobilization may not be necessary. If you are not averse to the fact that the patient needs to be on external immobilization, the anterior standalone would be adequate in the majority of these patients with burst fractures. There are certain tips when you are operating a burst fracture. The same applies as in situations like infections. There could be loss of orientation of the midline because of the disruption of the anterior nostril ligament and the injury to the longus colli. Therefore, it's important you get your orientation of the midline well. Therefore, when you are putting your pins into the vertebral body above and below, mark it with the cautery, and when you are checking the AT view, just be sure that's in the midline. As you can see in this post-operative radiograph, the plate is tilted to the lateral side, it's okay. It was lucky because this injuries, the inferior part of the plate will C7, but if it is at a higher level, there could be possibility that you might injure the vertebral artery. And if you are considering using a cage, then you can use the corpectomy as bone to fill the cage. And it's important that the screw fixation to be limited to the adjacent subchondral bone, or if the plate extends further into the disc space above, it interferes with the nutrition of the disc above and it can cause subsequent failure of the disc above. Therefore, a shorter construct of plate which is limited to the inferior part of the vertebral body above and the superior part of the vertebral body below is ideal when you are doing plating, especially in the anterior cervical spine. Coming to the situation of a fracture dislocation, there is no doubt in anybody's mind that these are the situations, and these are the situations whenever there is a fracture in the posterior elements, it's completely dislocated spine. I mean, you can be able to get the reduction by an anterior approach, but for a long-term safety and to prevent the failure of the implant, these are the situations where there is no doubt that you have to do an anterior posterior procedure to get the eventual good results and to prevent the failure of fixations. Coming to the most common pathology which we face and always there is a doubt in my mind is fascial dislocations. It could be either a mini-fascial dislocations or a bifascial dislocation. I would not take in. The important controversies in this situation is when to do the MRI, whether we should do the reduction by closed or open techniques and what approach to use, either an anterior, posterior or a combined approach. The MRI not only gives you an idea about the disc, it also gives you an idea about the posterior ligamentous injury. Is there a hematoma in the spinal cord? Probably some signal changes in the cord, but it can also, by carefully looking at the MRI, it also gives an idea whether the vertebral artery is injured. It's also important to realize that the major importance of MRI in cervical spine injury basically lies in the fact that identifying disc herniation, because we do know that unifascial dislocation, there is a 40% chance of disc herniation, whereas a bilateral dislocation, it could be as high as 80%. It gains prominence basically because the fact that when there is a dislocation, the herniated disc usually lies posterior to the vertebral body, and when you try to reduce, the disc fragment is displaced into the vertebral canal and can cause a compromisation to the already injured cord or a normal cord, and the patient can develop neurological deficit. This stemmed from this paper which was published saying that 3 out of 13 cases had neurological deterioration following a close reduction in the presence of a herniated disc. However, this recent paper from the spine trauma study group noticed that there is no permanent neurological deficit has ever been attributed to a close reduction of a cervical fascial dislocation in a patient who is awake, alert, cooperating. Therefore, the current recommendation is that in a patient without neurological deficit, it's important that you do an MRI before reduction to know whether there is a disc collapse. However, in a patient with neurological deficit, if you are not able to get an MRI very soon, there is no in-house MRI, and you are not able to get an MRI within an hour or two, then it's better to do an awake traction reduction before you proceed on to do the MRI scan. If you see this patient, the question is whether to go anterior, posterior, or a combined procedure. Each has got its own merits and disadvantages. The approach of the advantages of anterior approach is a broader surface area for anterior fusion. The offending disc can be safely removed. The supine position is maintained. A lower infection rate, and if there is a laminar fascial fracture, it precludes the use of the posterior fixation. However, anterior fixation is not without problems. Therefore, it may be difficult to reduce anteriorly, and also biomechanical and clinical studies have shown that anterior fixation is less stable than a posterior fixation. Therefore, it seems like a posterior approach could be an ideal option. But the question is how to get reduction. Either the reduction can be achieved either pre-operatively or intraoperatively. Majority of the centers worldwide is advocated that you do a close reduction first as soon as the paper comes. But the important thing when you are doing a close reduction is placing the towels on the head to recreate the flexure deformity, and the reduction should be monitored every 10 minutes where you need to increase the weight. When the patient complains of any change in neurological status, you may have to abandon it. If not, increase such that maximum up to 40% of the body weight till the facet gets this unlocked, and then to remove the towel so the neck goes into extension to achieve the reduction and reduce the body traction weight by 50%. And once you achieve that, it's important that fusion is necessary. You can plan for a fusion depending on your choice, whether to go for anterior or posterior. If it fails, then you have to contemplate a open reduction. Open reduction could be an anterior or a posterior, again depending on the surgeon's preference. The technique is basically, if you are doing an anterior one, which we use on a regular basis, is basically once you go in, remove the disc, use an interbody spreader, which is inserted in line with the interlaminar disc space. You distract the spreader so that the facet gets unlocked, and then you can rotate it to get to the reduction. It also helps if there is a traction that is applied, or anesthetist use traction when you are doing this particular manner. Or it can also be done as described by using a Casper pin distraction, where the pins are put divergent, and when you put the connectors, it unlocks the facet, and then you can push the superior vertebral body behind it. This patient was managed by an anterior discectomy and fusion, eventually having a complete neurological recovery and a good fusion. Similarly, as you can see in this particular case. If you are one who prefers to do a posterior technique, then you can do a direct facet release and then do a reduction. But the problem is whenever there is a presence of a disc herniation, if you are doing a fascectomy and try to pull the fragment behind, the chances that the disc might get displaced. Therefore, what is advocated is basically after putting the screws, you distract, disengage the facet and then try to reduce. In that situation, the disc is supposedly going back into the disc space, causing any particular problems. Therefore, should the nature of the injury influence your approach? Yes. If there is a significant posterior injury, as you can see here, this causes implant failure, it is probably better to go for an anterior posterior fusion. Biomechanical data says that the posterior is better, but in the clinical practice, what we have observed and majority of the literature has said that anterior alone surgery may be adequate. And surgery papers have shown that there is no major difference between the outcome. And what we do practice in unilateral dislocation with the MRI is post-disc herniation, preferable to go anterior. If there is no disc herniation, it is the surgeon's preference again to go whether anterior or posterior, depending on how they feel comfortable. And this is well shown by this article where they did a survey of 25 senior surgeons, and there is a decision factors varied on different situations. Therefore, to conclude, burst fracture anterior decompression and fusion is ideal. If posteriorly fractured combined and no standalone posterior, and festoral dislocation anterior and posterior gives same results. In our experience, in our practice, we use anterior alone posterior in these situations, but the choice is dictated by the choice of the surgeon and the training of the surgeon, whichever techniques, whichever approach you would like to prefer. Thank you.
Good morning. The pediatric spine injury is a separate entity quite different from its adult counterpart due to wide differences with regard to each aspect of spinal injury. Pediatric cases of cervical spine injury account for less than 10% of all such injuries. Rare in children, contributing to less than 1% of all children fractures. Quoted rates of neurological injury in children with cervical spine injuries vary from rare to 44% in large series. In contrast to adults in whom cervical spine injuries account for 30 to 40% of spine trauma, up to 80% of pediatric vertebral injuries occur within the cervical spine. In age less than 7 years, the majority of the cervical spine injuries are upper cervical, especially craniocervical junction, whereas age greater than 7 years, the lower cervical spine injuries predominate, and we will later try to analyze why it is so. The synchondrosis may also be confused with fractures. As we know, for the C1, the neurocentral synchondrosis fuse between age 6 and 8 years. For C2, it fuses between 3 to 6 years, and for C3 to C7, they fuse again between age 3 to 6 years. Now, amongst the anatomical differences, there is an increased elasticity of interspinous ligaments, the posterior joint capsule, and the cartilaginous end plate. The vertebral bodies are wedge-shaped and horizontal, and the orientation of the facet joints is horizontal, and this may predispose to upper cervical spine injuries. It also allows for greater mobility, flexion and extension, thus again predisposing to upper cervical spine injuries. As you can see here, the occipital C1 articulation is very axially oriented. The fulcrum of cervical spine flexion shifts caudally from C2-3 in early childhood to C5-6 by 10 years of age. This is basically because the shape of body changes to the adult nature by this age, and the orientation of the facets also changes to the adult nature by this age. So, in injuries more than 10 years of age, more adult pattern of injuries are witnessed. So, in children less than 9 to 10 years of age, you see more often subluxation without fracture and scivora, whereas more than 9 to 10 years, it's more fracture and fracture with subluxation that you would see. Also of importance is the size of the head in proportion to the body. In the children, there is a larger head when compared to the body. And the fulcrum, again, as we mentioned before, is C2, 3. The neck muscles and spine ligaments are weak and lax. And as we mentioned about the orientation of the facets and the vertebral body, it differs as such. The large head will cause an increased flexion of C-spine on a standard backbone. So there should be a bump placed beneath the upper thoracic spine or a cutout in the bone for head to transport child with spine in neutral alignment. Again, we should be aware of normal ossification centers and physis when evaluating the radiographs. C2, 3 pseudo-subluxation common in children younger than 8 years. And then we should check the spinolamellar line of fissure. And evaluation of soft tissues anterior to the spine may be unreliable in the crying child. We are aware about the posterior cervical line of fissure, which is used whenever we suspect subluxation of C2 on C3. The standard criteria to clear cervical spine by X-rays is followed. The Nexus guidelines, can they be applied to pediatric cervical spine injuries? These studies revealed that no cervical spine injuries were identified in pediatric group without at least one Nexus risk factor. About 20% less radiographs would have been performed if we follow this. And Nexus criteria, they concluded, can be used with caution in pediatric patients greater than 8 years. We are aware about the Nexus low risk criteria. The CT MRI indications in pediatric cervical spine would be altered mental status and risk factors, cervical spine incompletely visualized on plain films, abnormal or suspicious cervical spine films, the suspicion of injuries despite normal radiographs, and the CT sensitivity and specificity would be greater than 98%, and MRI is better than CT for soft tissues injuries, especially scivora. This clearance protocol as advocated by Anderson for cervical spine clearance after trauma in children. If the child is suspected to have an injury for children more than 5 years, an epilateral and odontoid open mouth view is done, and for children less than 5 years, an epilateral is done. If there is a normal radiograph, further evaluation if it is normal, and if it is not a communicative child, again a spine service consult should be done. If the child is communicative, you look for the Nexus criteria. If you can clear the child, fine. If no, you check for the neurological examination. If the neurological examination is normal, again you refer to the spine service consult. If it is normal, you get a flexion extension cervical spine X-ray. Again, if abnormal, refer for a spine service consult. And if they are normal, the cervical spine is clear. Now, when it comes to management, concerns of future growth because of future and growth arrest at the fused levels is to be taken into consideration. And children have improved recuperative powers such that many injuries that would require surgical intervention in an adult, including ligamentous disruption, may only need immobilization in a child. The basic principles of treatment otherwise would parallel those in adults, but knowing that many of them would respond to a conservative treatment more than that in the adults, and knowing that more injuries would occur in the cervical spine and especially in the craniovertebral junction. So, Atlanto-occipital dissociation has a very high incidence in the children, and many of these injuries, more than 60% of them are to be missed. So, there should be a high index of suspicion which should be there. So, for want of time, would not go into the details on each of the injuries, pediatric cervical spine injuries which can occur, but that there is a better prognosis for recovery. One would, even though treat aggressively, but many of them would respond to a conservative treatment, and late sequelae, that is paralytic, this neurovascular scoliosis can happen, especially if the injuries happen in a younger age group. Again, this study voices the same sentiments. Now, Scevora is again 18, contributes to 18 to 38% of pediatric cervical spine injuries, and you can have an injury because the flexibility of the vertebral column in the pediatric cervical spine is more than that of the spinal cord, and thus you can have a cervical spine injury without any injury to the vertebral column. One generally recommends that one should have at least 12 weeks of immobilization to prevent a recurrence. Os odontoideum, again, the exact etiology is debatable, but it could result in C1, C2 instability. It's usually asymptomatic, and there is a debate about participation in contact sports in those having this. Now, to conclude, understanding of the unique nature and growth potential of the immature skeleton is of paramount importance in treating a child with a suspected cervical spine injury. The pediatric cervical spine undergoes anatomical and biomechanical changes from infancy to adolescence. Thus, specific injuries are related to the patient's age. Advanced imaging may help the physician identify subtle injuries not evident on clinical presentation or plain radiographs. A high index of suspicion should be maintained. MRI can be used to clear the cervical spine in an obtunded patient and can provide prognostic information in a child with Scevora. Management principles are the same as adults, but larger number respond to conservative treatment. There are more chances of late sequelae, but there are better chances of neurological recovery in pediatric cervical spine cord injuries. Thank you.
Thank you very much, ladies and gentlemen. And special thanks to Dr. Chawla for doing all my talk. So I might spend some time telling you stories. This is a real life story. The very first time I went to England, I was doing an emergency room on call. And an elderly couple came with a road traffic accident. The lady got bad hurt with head injury, some rib fractures, and an open tibia. And I was managing open tibia, and she was admitted after initial management. And the gentleman who actually drove her here, he said before leaving, "Doc, you know, my neck is hurting, can you do something about it?" So my senior registrar said, "Okay, let us do an x-ray." And he x-rayed. He looked into the x-ray, we had a digital x-ray at that time. It looks okay, you know, fine. Where is it hurting? Okay, no, I think you'll be fine, and I know you are worried about your wife and all. Next day, morning, the gentleman didn't come to hospital. In the afternoon, he was brought to hospital, quadriplegic, being brought by the ambulance, because the neighbor had to knock his door. No one was listening to police go to the door. An ambulance picked him up, sitting in a chair, quadriplegic. You don't want this to happen to any of your patients. Neither you don't want to be a part of this story again, ever in your life. And that's what missing injuries in cervical spine is all about. So how often do you think that the person who comes to an emergency room brought by the ambulance may have a neck injury? What is the potential of having neck injury? It's just about 1% of those. The person with a serious injury that come in there, about 1% of them will have neck injury. And about half of them, 0.5%, will also have some degree of cord injury. So that's the amount of volume of neck injury that you are going to expect. So be on guard. Be on guard so that you don't move anything. If the history is massive, it's a major accident, polytrauma, the chance of having a serious neck injury is 3%. And if it involves the head injury or facial injury, it's even more. Almost 1 in every 10 person will have a cervical spine. So don't spare any time to evaluate. And how often they are missed? So not too short, but about 9%. And this is from a study published in Journal of Trauma 2002. And they found it is even more common if the patient is unconscious or elderly, or the spine is stiff, like with an AS or a dish kind of a lesion. There the chances of having a missed fracture is even higher. And in that group of the 52 patients missed, they found the highest incidences in mid-cervical and lower cervical spine, and some in thoracolumbar junction. So after reviewing the literature, I found the causes of missing injuries can be classified as number 1, failure to obtain an image, failure to recognize a fracture even after you have gotten the image, or the image you have done, you have gone through it carefully, but the fracture or dislocation was not shown. Those are the 3 ways you can have. Now, how often that happens? In this paper, they found 274 injuries in 5 years. They found 14% or 38 number of missed injuries initially that were recognized later on, and 30% cervical, 5% thoracolumbar, like in our previous experience. And what they found that the commonest cause for this large number of missing injuries was because the X-ray was not even obtained. So big lesion there. Another paper said 34% or 4.6% had a delayed diagnosis. And it is not just a delayed diagnosis, about a third of them developed permanent deficit. And many of them, the delayed diagnosis was not for obtaining the X-ray. As simple as that. And what happens, because you don't like to be in that situation, you then start doing X-ray for every little person. Every person comes to the door, get an X-ray before you even page me, and that led to criticism. And unless you come and see the X-ray and take the collar off, the patient has the misery of having the collar on, when they have to do intubation, IV line, ventilation, feeding, and all those stuff. So it becomes a little bit more critical than that well, we don't like to miss it, we don't like to overtreat either. So what if you have done the X-ray, what do you look for? Why you shouldn't miss that failure to recognize? John Webb, my mentor, long back, 1976, mentioned tetrad of signs. One is interspinous widening, anterior subluxation level, a teardrop fracture, and a focal kyphosis. None are hard signs, but these soft signs should stimulate you to look carefully or image even further so that you don't miss something. It's apparently innocuous X-ray, but a tiny teardrop and a loss of lordosis and also widening of the interspinous ligament here should warn you something more might be there and you shouldn't miss it and may need some surgery, whatever is appropriate. Once again, more or less innocuous looking X-ray, but a little bit of a step and also possibly a fracture, doesn't look like a normal shape, is a kyphosis, and raises suspicion. How you read those X-rays? Look for 4 lines: anterior vertebral line, posterior vertebral body line, spinal laminar line, and line of the spinous process. Are they forming a harmonious rhythm? And also don't forget the soft tissue shadow, even indirect evidence of an injury. And that is little larger behind the pharynx, but from lower border of C2 down to C4 is very minimal. It's about 4 millimeters. And then further up to C5 down, it becomes wider, about say 15 millimeter or 1 vertebral width of the body of the 1 vertebral body. The angulation between spinous process is about 11 degrees, which is difficult to measure, but one space between spinous processes should not be wider than one above and below. If it is, suspect something wrong out there. Like here is an example. Suddenly you find that the space between 2 spinous processes wider than above and below, and you suspect something wrong. And that was not suspected in 1992, and year 2000, the patient came back with further subluxation. And here you are almost about to miss unless you look carefully at the bottom end, because the lower end of the cervical spine is often covered by shoulder and is difficult to see. You can do an oblique, supine oblique image to see whether the facet joints are lined up to know what's going on. And if you have CT scan, you have the luxury to know everything what's going on. But most initial efforts are to look into carefully the plain X-ray. Loss of alignment, little subluxation, AP view of the spinous processes are aligned, and so on and so forth. Now here, now you have become a little more careful, wake up. Is there anything wrong? First day, nothing was found out. 3 weeks later, persistent pain, the CT scan showed that fracture. And you look back and see that image, and you find something suspicious out there. And more than that, the soft tissue shadow in front of C2, not 2 millimeter anymore. It's much wider, and that we missed. So it was seen that if X-ray is not good enough, how good is CT? And in this large study, they found X-ray may be false negative as much as 3%, and in CT scan 0%, meaning CT is a gold standard. So is that true? If we do CT for all, we can avoid it? And that was not true. In Vercaro's group, they found, this was the initial presentation, this is, they pointed out with an arrow, and I wouldn't object much to facility, it is more or less normal. And this is how patient came back because of persistent pain and needed surgical intervention. So clearing cervical spine become a problem. 7.5% cervical injury, 42% had unstable. And they looked into the sensitivity of each modality, plain X-ray, CT scan, MR scan, how good they are. The plain X-ray itself can miss in half of them. CT is not gold standard, can still miss 17%, 83% sensitivity, and MRI, 87% sensitivity. And the complication of collar is minimal. So unless you can get an MRI scan or unless you have a chance to re-examine at a future time, keep the collar on until you get the patient right. The missing injuries are much more common in obtunded patients, or if there is a delay, if there is any distracting injury. And those are the things that you have to be careful about. Because of lack of time, I'll go a little faster. So what is recommended? Obtain an X-ray, supine prostable and open mouth, and swimmers be careful about the cervicothoracic junction. And when you do it, if there is any tenderness in the spine or neurodeficit, is a blunt head injury, or the patient is intoxicated or obtunded, and in all polytrauma patients, always check the neck with the X-ray. And to reduce, so that you do not X-ray everybody, that's where the nexus criteria come in. And this was the American National Emergency Group said, if you find certain evidences, then you do X-ray. If none of those, then it's called NLC, the nexus low risk criteria, meaning low risk of neck injury, you can skip the X-ray. And those are those 5 points they outline that has already been discussed. The Canadian, they have a different health system, government pays for everything. So they have got a Canadian C-spine rule, more or less the same thing. They say, if you have this, do X-ray. If you can exclude all those, essentially if the person is alert, awake and can move the neck freely and no neurodeficit, you do not need to even do an X-ray. But this has been compared by this famous study published in New England Journal of Medicine, and comparing these two in a large group, they found that the Canadian rules is little more accurate, more sensitive and specific compared to the NLC rules. But still there is no golden rule, and each institute has something on their own. And we in Dartmouth, we have on our own 2 separate ones. One is for the awake patient. The children's are different, but the adult awake patient, and if you find the nexus rule going on, then you don't have to do anything. But any tenderness, etc., do a CT scan. Abnormal, go for an MR scan, call the spine surgeon. Normal, still be careful, keep the collar on. Check again next day before you let them go. And if the patient is obtunded, it is much more stringent that you do an imaging definitely. Even if it is normal, then keep it a collar until next morning the attending says, yes, it is normal, and check the patient again. Otherwise, go for a spine consult or do an MRI scan. I think both the lectures were more or less overlapping, so I will stop there. Thanks for your time.
Well, again, thank you very much for inviting me. This is the end of the current session, and coming to the end of the symposium. Most people have already said what I should say, so I'm going to introduce a little bit of controversy, maybe disagree with some of the things that are done, and instead of just being didactics, I'm going to put up a few cases and ask for your opinion. Now, odontoid fractures and non-unions. Everybody knows about them. Probably not, but let's see. Here's a good example of someone, and note that I'm using an MRI scan. This, I think, is the next stage after the previous speaker, after Dylan's saying, how do you tackle it? This is why we need scans. This is an elderly person who's fallen on his face. There are mild cord signs which have cleared by the time the patient has come into the ER. I have tingling in my fingers, doctor. I couldn't stand for a few minutes, but it's okay now. Can I go home? Yeah, maybe I can go home. And look what the MR showed. Look, first of all, there's the fracture. The posterior longitudinal ligament is still intact, but look at the cord. And this is a look back to what was said yesterday about signal changes in cervical myelopathy. This man, by the time he is examined, is neurologically intact. And look at the sign, the size of the signal. But it shows you what happened. All of this went back, caused an injury, and that's happening there. Now look lower down. This is why the elderly has a fracture at the top end. It's a last joint syndrome, and we must always remember that about the craniovertebral junction. Everything here is stiff, and so when he falls on his face, the only bit that can move is the top end. So these are all the things that you must think about when you see the plain X-ray and be prepared to look at and investigate by the time you're ordering a scan. We haven't said anything about how to treat this patient, and I'm going to ask you how to do it later. This is really a summary, and all the previous speakers have more or less said the same thing. Really, odontoid fractures, or in fact all cervical spine fractures, are underdiagnosed. There are probably 1 in 10 to 1 in whatever of cervical spine things. If you're over 70, as some of us are, it's the commonest neck fracture. And these injuries, the odontoid, occur in the very young and the very old. The biomechanics are a flexion and extension, a low velocity injury, the seat belt, the fall. When there's a rotatory element, there's usually a higher impact or a higher amount of energy, and we briefly touch on those as well. And you've heard already the causes. We said it yesterday, it's been brought up in today's speakers again. The odontoid peg, all that area is held, its stability is totally dependent on ligament, totally. And if you have anything where there are lax ligaments, it will make it very likely. Now, ossodontatum, I have to take issue with one of the previous speakers. For me, there is absolutely no doubt about an ossodontatum. I have to say, and I'll show you these things again, the reference to Fielding was true 30 years ago. Fielding wrote his paper on plain X-rays. Fielding did no post-mortems. Fielding never looked at the front per-operatively. So it is very important to realize that that seminal paper of Fielding's was absolutely true in the years before scans were invented. I think we now have a better understanding. And in fact, you can read the rest. That's an ossodontatum. What's in here? What's in here is terribly important when you say, oh, I'm going to put a screw in. Because the commonest cause of non-union of a screw there is the stuff that's in here. We'll talk about that again. And that's what you see if you dare to look from the front. There's a beautiful ligament. If you saw that at the ankle, you say, oh yeah, I know that the screw's not going to work in the lateral malleolus. I know it's not going to work because there's soft tissue. We in the spine think we're different. We think it's the spine. The bone and ligament rules are the same for every joint. Interposition of soft tissue is a big problem. Any joint. So, osteodontium, we may never know it happened. It may be part of a syndrome. You heard yesterday, if you've got a Morchios or SED, every one of them has an osteodontium. Progressive in head mouth, and some of them have neurology. Now, this was a paper almost about the same time as Fielding produced his paper. This is Shirk and Nicholson, who produced this case report in the Journal of Bone and Joint. And they had the answer. Look, they did the histology. Look, there is the reason when I can get the arrow. There is the reason for the osteodontium. There is the reason for the non-union. There is the reason for the repeated minor injuries with flexion and extension to cause damage to the cervical spinal cord. So, odontoid, osteodontium, may be incidental, as you've heard before. Or an ununited fracture, maybe a fall on the face. The patient presents with black eyes and a sore neck. Think about it. Later, they may say, you know, I fell a month ago. An old man, I fell a month ago. And if a patient puts his hand behind his ear, or her ear like that, or either side, if they do that, you know exactly where the pain is coming from. If the patient says, I've got a headache here, doctor, it's not a headache. It's irritation of the C2 nerve root. And the number of people who are at migraine clinics with headaches is very high. This equals the occipital nerve. So once they say that, think. Later, they'll say, funny, I don't seem able to get my head up straight as it used to be. Or they may appear years and years later, as I'll show you, with spastic limbs. And the next trick, which people forget, is the presentation of something around the foramen magnum, of compression, is wasting of the small muscles of the hand. Usually, unfortunately, if they go to a non-thinking spine surgeon, he does a lower cervical CT scan, which shows big osteophytes because they're 70. And they get a C6-7 disc. My hands are no better, doctor. My hands are no better. That's because it's up here. Wasting of the small muscles of the hand. Always think foramen magnum. So what are the treatment options? Well, you've heard, put them in warm collar. Or you can put them in a halo body immobilizer. If you really want to torture the patient. I think the days of halo body jackets need to be reviewed. And I think with a sophisticated audience like this, you people can do screws at the highest level of expertise. So don't torture patients. And I also have to say, and particularly to my American colleagues, don't include the occiput unless there's a reason. Certainly, I worry about the number of occipital fixations that are done in America for really reasons that are less than medically obvious. So let's come to the anterior screws. Yeah, it's dead easy, isn't it? Oh, all I do is put something down here and put it up. Be careful. The most important thing I told the residents is before you take them to the OR and you put them to sleep, take them to the X-ray room and put a large piece of metal from where you think the incision is along the line of the odontoid. If it doesn't go there easily, don't get them to sign the consent form for that operation. If they're squat necks, if they're very fat, the instruments will not go. And then it's very embarrassing to waken up the patient and say, sorry, I got you to consent for the wrong operation. So, outcome of odontoid screws, front and back, any of those things, you have to say, is there any evidence base? No, all the reports, regrettably, are retrospective surgical reports. Even when you say 25 senior surgeons gave their opinion, what does that mean? It's only an opinion, it's not science. So half the non-treated progress to non-union, and many of them, amazingly, are stable. So let's look at this one. Look at that. How would you treat that? 15 years ago, fell off a roof. So what has happened is he's had a complicated injury, and one of the things that you do is your head falls forward, and amazingly, what we are geared to do is look at the horizon. So you begin to walk like this, see the horizon, and as you walk like that, you get fixed in that position. So if a patient comes into you walking like that, be it ankylosing spondylitis or anything else, remember that he is fixing on the horizon, and there's a reason why he is like that. So, non-union, again, it's not an avascular necrosis. That is a figment of the orthopedic literature of 30 years ago. It's non-union, same way as an ankle. So, very quickly moving on, which patients? And the most important question, is the operation that I can offer better than the natural history of a non-union with fibrous healing? Unless you can answer that honestly, you shouldn't be offering them an operation. Okay, you may put a screw in, but there are technical reasons. You've all heard of this, you've all seen that. If I see that there, I usually think that there's a ligamentous injury that has been missed around the lateral ligaments. If you put a screw in that fracture, it will almost certainly get worse. So those are the things to think about. Pediatric non-union, we've been through all of this yesterday. Many are incidental. It was first described in 1863, so it's not that long ago. Management decisions with an orthodontatum, observe. If you have someone like a professional American footballer, he gets a sore neck, no one ever knew there was a problem, you do an x-ray and find an orthodontic. What do? Well, the US football people have now come up and said that has got to be fixed, although these people may not have known that they had a problem. Surgery, these are the options, odontoid screws. Give me another minute, please, of your time. Odontoid screws, I've told you about that. Mandrel screws, I don't think it's a good idea, particularly if you can't get reduction. This is probably the best form of screw, particularly if there's a rotatory element, and never include the oxalate. So, here's the odontoid fracture, and here's one where I would predict it will not unite. First of all, look at the subtleties, like the last speaker said. Look at the subtleties, look at that and that. That has had a rotatory element. That fracture there has a rotatory element. An odontoid screw will fail. That's one for a harm's goer. Look at this. This is torture. Poor child, it will not unite. Don't offer it. This is a fixed union, a cross union. That needs decompression. And there's no amount of spacers that will be put in the back, yesterday's talks, that will lift that up. It's cross union and it's solid. It needs a ventral decompression. Okay, just very quickly. 73-year-old, she's fallen. She comes into casualty. She's unsteady on her feet. She's fallen many times. She likes the old glass of sherry. She comes with another fall. She's no neurology. There she is. What are you going to do? What are you going to do? Okay, then X-ray. Hard to see. What will you do? Okay. Hands up those who do a odontoid screw. Any offers? Odontoid screw? Hands up, oh, I'm going to show you. Hands up, it's perfectly straight. Hands up those who are going to do a harm's fixation.